Welcome to the deep dive. Today, we're plunging into a really fascinating and, frankly, crucial area, hyperbaric oxygen therapy, HBO2.
Right, specifically its potential for treating traumatic brain injury, TBI.
Exactly. We've gathered quite a collection of research here, preclinical stuff, clinical trials, the whole gamut. Our mission really is to pull out the key insights and figure out where things stand right now.
And it's so important. TBI's global impact is just huge. In the U.S. alone, you're looking at nearly 4 million cases a year.
Wow, 4 million.
Yeah, leading to hundreds of thousands of hospital stays,
Yeah.
tens of thousands of deaths. And the cost, direct and indirect, we're talking tens of billions.
That's staggering.
What's really concerning, too, is that severe TBI often affects younger individuals. And despite a lot of research, the clinical outcomes for these severe cases, well, they haven't significantly improved since about 1990.
That really drives home the need to look seriously at other potential treatments, like HBO2. Now, I think most people have a basic idea of hyperbaric oxygen breathing pure O2 in a pressurized room.
Sure, that's the general concept.
But its use for TBI, that's evolved quite a bit,
I
hasn't
know,
it?
absolutely. Decades ago, the main idea was that HBO2 could help by constricting blood vessels slightly, lowering pressure inside the skull,
Okay.
while simultaneously packing more oxygen into the blood to reach those injured brain cells.
So better oxygen delivery plus managing that dangerous swelling. Makes sense. But the modern view, the stuff in our sources, it paints a more, well, intricate picture.
It really does, and this is where it gets particularly interesting. The focus now is shifting towards the cellular level.
The mitochondria.
Exactly, the cell's energy factories. Current research, both in animals and humans, it suggests HBO2 might actually improve how the brain uses oxygen to produce energy after the injury.
Okay.
We're seeing hints in clinical studies, lower death rates, better functional outcomes in some severely injured patients. It points towards maybe mitigating those long-term energy problems TBI survivors often face.
Which could be massive for recovery, for quality of life.
Potentially, yes. It's a significant shift from just thinking about oxygen delivery and pressure.
And with this growing body of evidence, there's a real push in the scientific community now.
Right, definitely. The goal, as our sources really emphasize, is to get a large-scale, multi-center, prospective, randomized clinical trial off the ground.
The gold standard.
Precisely. That kind of rigorous study is what's needed to say definitively whether HBO2 is truly effective for severe TBI.
Now, we need to be really clear here. Our focus today is specifically on acute severe TBI,
Yes, that's a crucial distinction.
because the evidence looks quite different for, say, chronic mild TBI, doesn't it?
It absolutely does. The studies looking at HBO2 for chronic issues like persistent post-concussion symptoms, they've generally not shown a positive effect. It's likely different biology at play compared to an acute severe injury. Plus, the animal studies just haven't shown HBO2 doing much physiologically in those chronic states.
Okay, good distinction to make early on. So let's unpack the preclinical work first. These animal studies laid a lot of the groundwork. Let's start with Virginia Commonwealth University.
Right, the work by Doherty, Zhu, and others there. They used a well-established model, the lateral fluid percussion injury, or FPI, in rats.
Okay.
And they compared a few groups, sham-injured rats, injured ones serving as controls, and then injured rats treated with HBO2 specifically 1.5 atmospheres for an hour.
Got it.
Followed immediately by what's called normobaric hyperoxia, or NBH. That's just breathing 100% oxygen at normal pressure for 3 hours.
Yeah.
Some studies also looked at NBH alone for 4 hours.
And they started treatment quickly.
Very quickly, just 15 minutes after the injury in these models.
Okay, so what jumped out from those VCU studies? What were the key takeaways?
Well, a few really significant things. First, that combined HBO2-NBH treatment dramatically increased the actual oxygen levels measured in the brain tissue compared to controls.
More oxygen getting in.
Yes. And they also saw a significant jump in the brain's overall oxygen consumption with the combined therapy. Critically, the injury itself caused a big drop in mitochondrial redox potential, basically, a measure of how well the mitochondria are working.
Right, that energy deficit we mentioned.
Exactly. But the HBO2-NBH treatment completely reversed that drop within just 4 hours post-injury.
Wow, okay. That seems pretty direct evidence for fixing that energy problem at the cellular level. What about ATP, the actual energy currency?
Good question. The injuries significantly reduced ATP levels in the cortex, but both the combined HBO2 NBH and the NBH alone brought those ATP levels back up significantly compared to controls, even just 1 hour after treatment ended.
So just getting more oxygen, whether under pressure or not, helped restore some immediate energy production.
It appears so, at least initially, but the benefits of the combined therapy seem to extend beyond just that immediate metabolic boost.
How so? Did it affect longer-term outcomes like thinking or memory?
Yes. The rats treated with HBO2-MBH showed much better cognitive recovery. They learned faster in the Morris-Water maze, which tests spatial learning and memory.
Okay.
And perhaps even more importantly, when they looked at the brain tissue itself, there was significantly less neuronal loss, fewer dead brain cells in key areas of the hippocampus, like CA23 and the hilus, in the HBO2-MBH group compared to controls and the group that only got NBH.
So it wasn't just a temporary fix. It looked like actual neuroprotection, saving brain cells, leading to better function later on.
That's what the data suggests, yes, a protective effect.
Now, our sources also cover work from the Technion Israel Institute of Technology. They use a different model.
They did. They used a cerebral contusion model, more like a direct bruise on the brain created by dynamic cortical deformation, or DCD.
Okay.
Here they compared injured rats to those treated with HBO2, but at a higher pressure, 2.8 atmospheres in 2 daily 45-minute sessions for 3 days, starting about 3 hours post-injury. Some studies also looked at rats that had low oxygen levels, hypoxia, after the injury.
Right. And what did they find regarding the injury itself, the lesion size?
Consistently, the HBO2 treatment significantly shrunk the lesion area and reduced its severity.
Oh.
And this effect was even stronger in rats that were both injured and hypoxic before getting HBO2 compared to hypoxic controls. They also looked at cell death markers.
Like apoptosis.
Exactly. They used 2-null staining, which marks cells undergoing programmed cell death. HBO2 significantly reduced the number of these 2-null positive cells.
Suggesting it's actively stopping cells from dying off after the initial hit.
That seems to be the implication. It looks like it might interfere with those cell death pathways.
Did they look into the mechanisms? How might it be doing that?
Yes, they looked at apoptosis regulating proteins. They found HBO2 boosted the expression of BCL2, which is a well-known anti-apoptotic protein, in the penumbra, that vulnerable zone around the main injury.
So promoting cell survival signals.
Precisely. Plus, they found HBO2 helped reduce cerebral edema, the brain swelling, which itself causes a lot of secondary damage.
So similar themes across different injury models, reducing lesion size, saving neurons. What about inflammation? TBI triggers a big inflammatory response, right?
It does, and that can often make things worse. Lodowski's study looks specifically at this. They found both HBO2 and NBH reduced the infiltration of neutrophils, a type of inflammatory cell, into the injured brain.
Okay.
But the effect with HBO2 was stronger and lasted longer. HBO2 also significantly cut down the expression of MMP9.
What's MMP9?
It's an enzyme that breaks down the scaffolding around brain cells. Reducing it could help maintain tissue integrity after the injury. So HBO2 seems to dampen that potentially harmful inflammatory cascade.
Interesting. And there were studies looking even more closely at the mitochondria and apoptosis pathways.
Yes. They found HBO2 significantly reversed the injury-induced loss of mitochondrial transmembrane potential that's crucial for energy generation.
Right.
And this recovery lined up with reduced activation of caspase-3 and 9 key executioner proteins in the mitochondrial apoptosis pathway. Interestingly, not caspase-8, suggesting a specific route of action. They also saw fewer cells expressing TSPO, which is linked to mitochondrial stress and cell death pathways, and fewer 2-null positive cells near the lesion with HBO2.
It really builds the case that HBO2 isn't just about flooding the tissue with oxygen, but actively influencing these core cellular survival and death processes.
Exactly. It seems to be interacting at a much deeper metabolic and signaling level.
Now, in any acute injury treatment, timing is everything. What did the study by Wang and colleagues show about the window for treatment?
That was a key study. They used a rat contusion model and tested single HBO2 treatments at different times, 3, 6, 12, 24, 48, and 72 hours post-injury.
Yeah.
A single treatment at 3, 6, or 12 hours worked. It significantly improved neurological scores, reduced brain swelling, saved hippocampal neurons, and reduced cortical apoptosis.
But later,
A single shot at 24, 48, or 72 hours. No significant benefit.
Okay, so early is key. What about multiple treatments?
Multiple treatments, say daily for 3 to 5 days, starting within 24 hours, were even better than a single early treatment. Starting multiple treatments later at 48 hours showed some improvement, but less than even a single early treatment. And starting at 72 hours, no benefit at all.
So the message from the preclinical side seems pretty clear. Early intervention, potentially multiple sessions, yields the best results. There's a definite window.
Absolutely. The sooner the better, at least in these models.
Okay, this preclinical evidence definitely lays a strong foundation. Let's shift now to the human clinical trials. Our sources mentioned some older work first, by Holbach et al.
Yes, Holbach's study is older, and we have to acknowledge its limitations, like it wasn't blinded, the randomization wasn't ideal, treatment varied.
Yes, sure.
But it looked at 99 comatose TBI patients. The group getting HBO2 had a much higher rate of complete recovery, 33% versus only 6% in control.
That's a big difference, even with limitations.
And significantly lower rates of death or ending up in a vegetative state in the HBO2 group too. So an early, albeit imperfect, signal of potential benefit in very severe cases.
Which likely spurred more rigorous research, like the first prospective randomized controlled trial, or RCT, by Roxwold and his group.
Exactly. That was a landmark study. 168 severe TBI patients randomized within 24 hours to either standard care or HBO2 at 1.5 atmospheres for 60 minutes, 3 times a day for 14 days.
A pretty intensive regimen.
It was, and importantly, they showed it could be done safely and systematically in the ICU setting.
And the outcomes.
They found a significant drop in mortality at 12 months in the HBO2 group, 17% versus 32% in controls.
Wow, nearly halved.
Especially noticeable in patients with poor prognostic signs initially, high intracranial pressure, ICP, needing surgery for hematomas, very low GCS scores.
But what about functional recovery?
That was the interesting part. Using the standard way of measuring outcome at 6 months, the dichotomized Glasgow Outcome Scale, or GOS, they didn't see a significant improvement in favorable outcomes overall.
So fewer deaths, but not necessarily translating into better overall function by that standard measure at that time point. That's puzzling.
It is a bit, although our sources mention a later reanalysis of that same data.
Right. What did that show?
Using a slightly different way to analyze the outcome, called a sliding dichotomized GOS, which can sometimes pick up more subtle improvements in severely injured patients.
Okay.
That reanalysis did suggest a potential for improved favorable outcomes in some patient subgroups. It hints that the standard GOS might not capture the full picture in these complex cases.
That makes sense. Maybe HBO2 helps some survive who would have died, but they still have significant long-term issues, blurring the lines on that broad scale.
That's a plausible interpretation, yes. It highlights the complexity of measuring outcomes after severe TBI.
Roxwold's group also looked specifically at what HBO2 does to brain metabolism and pressure.
Right, they did. In a study with 37 severe TBI patients, they gave HBO2 once daily for 5 days. They found it increased cerebral blood flow, CBF, and the brain's oxygen metabolic rate, CMR2, after treatment, particularly in patients whose baseline flow was low or normal.
So boosting oxygen use.
And they saw a consistent drop in lactate levels in the cerebrospinal fluid, which suggests the brain is shifting to more efficient oxygen-based energy production.
Away from that less efficient anaerobic metabolism.
Exactly. Plus, in patients who started with high intracranial pressure, the HBO2 treatment significantly lowered it. And these effects happen whether treatment started within 24 hours or up to 5 days later.
Suggesting it's enhancing the brain's ability to use the oxygen it has, not just delivering more.
That seems to be the implication, yes. Improving metabolic efficiency.
Then they did a head-to-head comparison, HBO2 versus just high-flow oxygen at normal pressure, the normobaric hyperoxia, or MBH.
Sure.
What did that reveal?
A really crucial study. 69 severe TBI patients randomized to HBO2, NBH, or control. They continuously monitored brain tissue oxygen, BBTO2.
Yeah.
HBO2 had a significantly greater positive effect on cerebral metabolism on CMR2 compared to NBH.
So the pressure matters.
It seems so. They found that getting brain tissue oxygen above a certain threshold, around 200 millimilli Hg, was linked to a really robust metabolic boost. And HBO2 achieved that level much more often than NBH. Also, the positive metabolic effect of HBO2 lasted longer, somewhere between 6 and 24 hours post-treatment.
A sustained effect.
Yes. And importantly, HBO2 lowered ICP, while NBH did not. And critically, no signs of oxygen toxicity in the brain or lungs in either hyperoxia group.
That seems like strong evidence for the specific benefit of the hyperbaric component.
Yeah.
And finally, they tested combining the two, HbO2 followed by MBH.
Yes, their last RCT we're covering looked at that combined approach in 42 patients, HbO2 for an hour, then MBH for 3 hours versus controls.
And the results there.
Very positive. The combined therapy significantly improved those markers of oxidative metabolism, both in relatively uninjured tissue and the paracontusional area. It also reduced intracranial hypertension.
Still no toxicity issues.
No signs of oxygen toxicity. In fact, markers associated with brain damage actually improved after the combined treatment.
Wow, that's counterintuitive maybe, but suggests a protective effect.
It does. And the clinical outcomes were striking. A statistically significant improvement in functional outcome and a big drop in mortality. Mortality was 16% in the combined HbO2 and BH group versus 42% in the control group.
That's huge.
And using that sliding dichotomized GOS, 74% in the treatment group had a favorable outcome compared to only 38% in the controls.
Okay, those later clinical trials, especially the combined therapy one, paint a very encouraging picture, but let's talk practicalities. Availability, safety. These are big hurdles.
Absolutely. Availability and cost are major factors. Hyperbaric chambers aren't everywhere, and they're expensive.
They're different types, right?
Yes. Multi-place chambers, big ones that can hold several patients and staff, and monoplace chambers for single patients.
Okay.
Monoplace chambers are becoming more common, potentially easier and cheaper to integrate into an ICU setting.
But is it safe to put these critically ill TBI patients, often on ventilators with monitors, into a pressurized chamber? And what about oxygen toxicity? That's always been a concern.
Based on these trials, especially Roxwold's work, it appears to be a relatively low-risk procedure when done carefully.
How do they manage it?
Particularly in monoplace chambers, they can continuously monitor everything: ICP, blood pressure, cerebral perfusion, CO2, even brain tissue oxygen. There are some contraindications, like if a patient already needs very high oxygen levels on the ventilator.
Right.
But they have protocols, rapid decompression options for emergencies, and often do a routine minor ear procedure, a myoronotomy, to prevent pressure issues.
And the oxygen toxicity worry. Lungs, brain.
Roxwold's group looked closely at this. For the lungs, they didn't see increases in key inflammatory markers like IL-8 or IL-6 after HbO2. Serious lung issues were rare and usually reversible.
Okay. And the brain, it uses a lot of oxygen, vulnerable to damage from too much.
Theoretically, yes, lipid peroxidation is a concern. But they measured markers for this, like F2 isoprostanes and glycerol in the CSF. And levels of these markers actually decreased significantly after the combined HbO2-NBH treatment. Yes, suggesting that at these pressures and durations, the treatment might actually be protective against neuroinflammation and free radical damage, rather than causing toxicity.
That's fascinating. So the overall safety conclusion.
The conclusion from this body of work is that HbO2 treatments at 1.5 atmospheres can be given safely to severe TBI patients with a low risk of oxygen toxicity, provided proper monitoring and protocols are in place.
So practical issues like access and cost are real, but the safety profile, based on this research, seems manageable.
Exactly. Those historical fears about toxicity, while understandable, don't seem to be bearing out at the specific treatment parameters used in these severe TBI studies.
This has been a really illuminating deep dive. So to kind of wrap up the main points, our understanding of how HbO2 might work has really shifted.
Definitely. From just pressure and basic oxygen delivery.
Right, to this idea that it's working at the mitochondrial level, improving how the injured brain actually uses oxygen for energy.
And the clinical trials, while the early ones had flaws, the more recent rigorous ones, especially testing that combined HbO2-NBH approach.
They're showing some really promising results, reducing deaths, improving functional outcomes in severe TBI.
And it's important to acknowledge that historical controversy, the debates around safety and oxygen toxicity.
Yeah.
But the experience reported here, particularly from Roxwold's extensive work, suggests complications are rare and typically reversible with the right protocols.
So, looking ahead, it really seems to come down to that big trial, doesn't it? The large-scale, multi-center prospective RCT.
That's the crucial next step identified in our sources. It's needed to definitively confirm these promising findings and see if HbO2 should become a standard part of severe TBI treatment.
Which brings us to the final thought for you, our listener. Thinking about everything we've discussed, what do you find the most compelling reasons to keep pushing forward with HbO2 research for severe TBI?
And conversely, what do you see as the biggest hurdles beyond the big trial itself to making this potentially accessible if it proves effective? Things like cost, logistics, training.
And maybe stepping back a bit, what other questions does exploring something like HBO2 raise for you about the brain's own resilience, its ability to heal, and how receptive it might be to other novel therapies we haven't even fully explored yet?